there was better control of ascites. However, Shrestha et al. Did show that the survival did not improve with the usage of midodrine. Similarly, in albumin, there has been three large-scale RCTs: the ANSWER trial, the MATCH trial, and the ATTAIR trial. The results have been a bit contradictory, whereas the ANSWER trial did show an improvement in survival by 11% after usage of 18 months. The same was not seen in the MATCH trial and ATTAIR trial. At the same time, the systematic review that were done on the usage of routine albumin infusion found that although there was lower risk of recurrence of ascites and lower endoparasynthesis, similarly to midodrine, it did not result in an improvement in the mortality. So, a recent study from our department had shown that midodrine usage did reduce the new onset AKI and hyponatremia in children, but it did not improve the overall survival or the native liver survival. So we had a hypothesis that perhaps by using albumin, which is a plasma volume expander, it might act synergistically to midodrine, and they may target a complementary aspect of circulatory dysfunction in the children with DCLD, and thereby improving the ascites control as well as improving the survival. The same can be seen here in the picture. Now, the aim of our study was to evaluate whether a combination of oral midodrine and intravenous albumin reduces the complications of cirrhosis in children with cirrhosis and ascites awaiting liver transplant compared to midodrine alone at 6 months duration. The primary objective was to compare the composite incidence of cirrhosis-related complications like acute kidney injury, non-resolution of ascites, spontaneous bacterial peritonitis, hyponatremia, and hepatic encephalopathy in children with cirrhosis and ascites who are awaiting liver transplantation. We will receive a combination of midodrine and albumin versus those who will receive midodrine alone. We had various secondary objectives, namely to compare the rate of control of ascites in between the two groups at 6 months, to compare the survival with native liver as well as the overall survival between the two groups, to compare the change in mean arterial pressure over time, to compare the change in plasma activity over time, to compare the change in serum sodium, serum creatinine, and the cytokine levels from baseline to 6 months. We also wanted to compare the frequency of development of drug-induced adverse effects. So this was an open-label randomized control trial conducted in the Department of Pediatric Hepatology, and it was approved by the Institutional Ethics Committee. It is registered under CTRI and CT. We did the study from ethical approval and started at December 2023 and completed it in June 2025. We included the children under 18 years who had proof of cirrhosis based on histology or imaging and or endoscopy, who had clinical ascites grade 2 or grade 3 and who were awaiting LT. The children who had hypertension, that is a MAP over the 95th percentile, or portal venous thrombosis, or hepatorenal syndrome as baseline, or congestive heart failure, respiratory failure, septic shock, hepatocellular carcinoma, any TIPS, or renal protein loss were excluded from our study. And we did randomization with IWRS with a block size of 4. So we had 2 limbs in our study. One limb was midodrine plus albumin limb, and the other one was midodrine only. In the limb with midodrine plus albumin, we gave routine albumin infusion 1 gram per kg over 8 to 12 hours every 2 weeks if the pre-infusion serum albumin was less than 3.5 gram per dl. Along with it, we also gave oral midodrine, which started at a dose of 0.25 mg per kg per day, and we escalated it to a 0.5 mg per kg per day dose if the mean arterial pressure at day 7 did not show an increase of more than 10% from the baseline. Alongside, we also continued on the standard medical therapy. Whereas in the midodrine limb, we gave the same dosage of midodrine along with the standard medical treatment. We did appropriate statistical analysis. The sample size, because we did not have any prior pediatric study on the combination of albumin and midodrine in pediatric CLD, we designed it as a pilot trial and took a sample size of 30 in each of the limbs. So coming to the results. Overall, 252 CLD children were assessed for eligibility. 70 of them fulfilled our inclusion criteria. We excluded 9 of them due to the various reasons like HCC, septic shock, etc. And ultimately randomized 61 children. 29 of them ended up in the albumin plus midodrine limb, and 32 went in the midodrine only limb. Among the albumin plus midodrine limbs, 3 were lost to follow-up. From the midodrine, 2 were lost to follow-up. So we did our final analysis on 26 children in the albumin plus midodrine arm and 30 children in the midodrine only arm. The predominant etiology in both the limbs was biliary atresia, amounting to almost 50% overall. So when you compare the baseline characteristics in both the study arms, they were comparable when clinical parameters were considered, and they were comparable when lab parameters were considered. Even the severity markers, the severity scores like PELD, CTP, and even the INR was comparable in between the two groups. So first, coming to our primary outcome measure, where we compared the composite and various incidents of complications in cirrhosis. In the albumin plus midodrine arm, the composite incidence of complication was 50% at 6 months, compared to 60% in the midodrine only arm, showing that there was a trend towards less complication in the albumin plus midodrine arm. Not only that, the appearance of the first complication was delayed in the albumin plus midodrine arm by almost 30 days compared to the midodrine only arm. However, this was not statistically significant. The same can be seen in this Kaplan-Meier curve, that the complication is appearing a bit delayed in the albumin arm, but it's not statistically significant.
Can you go to your baseline characteristics?
Yes, sir.
You were giving to the GI bleed patients also albumin or
Yes, sir. We had actually seen that there were no episodes of GI bleed in the patients who had a prior history of GI bleed who we had enrolled. They did not develop any GI bleed with albumin infusion.
what is the mean arterial pressure? I couldn't get the baseline map.
Yes, sir. That was also comparable, sir.
Okay, please go ahead.
Okay, sir. So coming to the secondary outcome measures, we had seen that in the albumin plus midodrine arm, the non-resolution of ascites was at 46%. And in the midodrine arm, it was at 43%. And these two arms were comparable statistically. Similarly, new onset AKI, new onset spontaneous bacterial peritonitis, new onset hyponatremia, and new onset hepatic encephalopathy, as well as the requirement of large volume paracentesis, all were comparable between the two study arms. When we compared the survival, 53.8% in the albumin plus midodrine arm survived with their native liver, compared to 46.7% in the midodrine alone arm. Although there was a trend of better survival with native liver in the albumin arm, this difference was not statistically significant. Similarly, the overall survival between the two study arms were comparable. The same we can see in the Kaplan-Meier curve, that the survival with native liver and the overall survival was comparable in between two of our study arms. So we set out to investigate that why this addition of albumin did not translate to a better control of ascites, lesser complication, and improved survival. Something interesting that we had found was that even in those children who were supposed to get midodrine alone, they received off-protocol albumin due to various standard indications. Almost 77% of the children who had in the midodrine alone arm received off-protocol albumin, predominantly due to large volume paracentesis, but also due to spontaneous bacterial peritonitis or AKI, or a combination of them. So this might have offset the difference that would have otherwise been present between the two study arms. However, this just reflects a real life scenario where in a real world practice, albumin would anyway be needed in any DCLD children due to standard indications. And even the study by Ashita et al., they had reported a median cumulative albumin of 5 gram per kg over a study period of 6 months. So this is a lack of statistical significance, but this does not undermine the efficacy of albumin in treating these children. There are other causes. Perhaps a relatively small sample size did give a lower statistical power. And we had a shorter duration overall. It was 6 months duration. We gave albumin less frequently. We gave once every 2 weeks. When you look back at the trials that had done earlier, the ANSWER trial, which had shown a significant benefit, they had given routine albumin over 18 months, and they had given weekly albumin, more frequent than what we give. Even the studies that were done earlier by Pascoli et al. Or Gentilini et al., they were of longer duration, 24 months and 36 months respectively. Compared to them, MAST trial, which just like our, did not show any significant difference in the survival, actually was of 12 months duration, and they give once every 2 weeks. But weekly albumin is perhaps not feasible in our setup. Also, we had heterogeneous etiology in the both the arms, and biliary atresia was predominant etiology, which somewhat behaves differently from other pediatric CLD. The other factor being we use midodrine in both of our arms. So if we can see that yes, midodrine and albumin act synergistically, but midodrine works in the same mechanistic pathways as albumin, and the only difference what is there is in the systemic inflammation, which is targeted only by albumin. So perhaps because of this, we could not find a significant statistical difference in the two arms. We also did a cost analysis, and albumin plus midodrine arm, the children who were enrolled, they had a much significantly higher cost of treatment than the midodrine alone arm. And we have to mind that this does not include the cost of hospitalization. So what this tells us? This tells us that midodrine can be very significant in a resource limited setting in DCLD children because it is comparatively cost effective. It is easily administered orally, and it does not require intense monitoring or hospitalization, which albumin would require, and at a higher cost. So we also did mechanistic evaluation to find out the reason for the results we got. We found that in both albumin plus midodrine arm as well as in the midodrine arm, the heart rate significantly declined over the first 1 month. Even the MAP significantly increased over the first 1 month. Although in between the two groups at any point of time, the changes were comparable. Something interesting was that plasma renin activity did not significantly change over time in either of the groups. And this is in contradiction to the study of Ashita et al., which was on midodrine in pediatric DCLD. Reason might be that the usage of diuretics and carvedilol were more common in our study group, and carvedilol being a direct antagonist in the same receptor might have impacted the change of PRA. When you go in for the renal parameters, the serum sodium, it significantly improved over a period of 3 months in both the groups. Such a change, although, was not seen in creatinine. And when we compared the cytokine levels from baseline to 6 months, we had seen that both TNF alpha, IL-6, as well as their delta from 0 to 6 months was comparable in between the two groups. However, although there was decline in both the limbs, even in the albumin limb, the TNF did come down from baseline to 6 months. The midodrine limb, the TNF did come down from baseline to 6 months. IL-6 also came down in both the study arms from baseline to 6 months, but it was statistically significant only for interleukin 6, this change in the albumin arm, not in the midodrine arm, which possibly is due to the immunomodulator properties of the albumin, which is taking down more chronic mediator like IL-6 better over a 6-month period and not being able to do the same in TNF alpha, which is more of an acute phase response. Regarding the safety, both the drugs were deemed safe, and albumin had only caused 2 cases of minor wheeze, which settled down with temporary discontinuation. In the midodrine arm, there was one child who developed hypertension, but he was on concomitant high-dose steroid therapy, and over 3-4 days, the hypertension also did resolve. This is somewhat in contradiction to what we had seen in ATTAIR trial, where they had reported in albumin infusion group, there was a 22% life-threatening event. 4% of them had pharyngeal bleed, 5% had pulmonary edema, which we did not find in our study group. Similarly, the meta-analysis by Sandy et al. Had reported a pulmonary edema with a relative risk of 3.14. Again, we could not find the same. One possible reason might be the slow rate of albumin that we had given. We had given over 8 to 12 hours in hospital. That might have led to a lesser incidence or no incidence rather of these complications that were seen earlier in other studies. So our study did have various limitations. We did have a limited sample size, and it was difficult to achieve in pediatric otherwise. It was a single center study. There was significant off-protocol albumin usage. There was heterogeneous etiology. with biliary atresia being a significant chunk, and we had a shorter duration of the study. To conclude, we can say that adding prophylactic albumin infusion to midodrine did not result in a reduced complication of cirrhosis, did not give better control of ascites, also did not improve the native liver survival or overall survival. And significant proportion of the pediatric DCLD will anyways need albumin in a real world scenario. So prophylactic albumin did not improve the outcomes, but it came at a significantly higher cost to family as well as to healthcare.
Comments from the guide.
So this was a follow-up study to our previous thesis done by another of our student, Ashrita, where she showed that midodrine reduced complications. So we wanted to go further and evaluate the role of albumin. As he has already pointed out, for the possible reasons that we couldn't find the effect of albumin that we discussed, mainly the duration. So duration of 6 months is possibly insufficient because, as shown, the bigger trial, the ANSWER trial, went on for like 18 months or 24 months, and only then they could show only 10% difference. So to show a 10% difference in the outcome, we need a very large number of sample size, a bigger sample size, which is not achievable in pediatric cirrhotic population. So 18 months compared to the shorter duration trials have shown no benefit. So that is one thing. And the other important take home point is albumin requires admission, higher costs. And anyways, we showed that 3/4 of our patients who are on midodrine arm will anyways require albumin for the standard indications. So as of now, the take home would be no prophylactic albumin and only albumin as and when required for standard indications in cirrhotic ascites awaiting liver transplant. However, if we go with a longer trial with a bigger sample size, the results may change, and the results may also change if we have one arm with albumin plus midodrine and one arm with just SMT without midodrine. So then albumin plus midodrine may have significantly better outcomes, including the control of ascites. And in that case, that needs to be evaluated further in maybe next study or something.
Can you go to your title? Title. So the whole attempt looks like you're trying to say albumin, why is it not effective? The idea is not, you're trying to say that albumin is needed, but we couldn't show albumin is needed. I mean, there is a reason. So the whole debate is not on that. Whole debate is a RCT, whether midodrine alone or, albumin is needed or not. That is the whole idea. And I thought the study has been very well done. But before I say, Rakhi wants to say something. Rakhi, you have any comments?
Yeah, so I have several reservations on your conclusions of the results which you're trying to show. This trial is actually because the patients did not complete the protocol. You yourself are saying that. Then everything is statistically not significant, but you are trying to say, no, everything is significant, even though statistical significance did not reach. So the conclusions which you're deriving, actually, it's a negative trial, first thing. Second thing, many patients, 70% got albumin. So that means in the midodrine arm, they were getting those complications and requiring albumin and getting better. This is very clear. So if they're getting complications, you're giving albumin out of protocol. So that means the number of complications that are developing in the midodrine are very high and they're requiring albumin. The third thing is, whenever you give midodrine in grade 2 ascites, I do not see any indication to give midodrine in a grade 2 ascites patient. The diuretic dose and everything has not been shown. Cumulative number of paracentesis. If you're looking at ascites, these are important parameters that have to be assessed from sequential follow.
Go to your table where you have shown complications, new onset. Yeah.
So median LVP is there. It's actually 0, 0, but the numbers are wide variation. This is the median and IQR, so it's 0 to 1. But as many as 8 to 9 therapeutic paracentesis.
Everything 43%, 46%.
Yeah, so it is completely not comparable.
not
We are, so
significant.
conclusion was the same, ma'am.
So
There is
we-
no benefit in the
So
there
we
was
cannot say
no difference in the
midodrine is
two.
good. And the second thing is to propose midodrine in ascites grade 2, where the map is usually preserved. There the diuretic, how were they dosed? How did you assess for diuretic non-response? That protocol has not been mentioned. Go back to your table 1.
Yeah, this one.
Table 1, please. The baseline characteristics. Go see the serum albumin levels. Go back. Yeah. Look at the serum albumin levels in the midodrine alone. 2.53. So I'm not sure because any studies have excluded patients who have very low serum albumin because they're denying somebody a treatment which is required. Midodrine will not help in this. And we're not saying target serum albumin, but we know low serum albumin predicts outcomes. It is a marker in all these scores. Now the MEL 3.0 incorporates albumin levels just to show the relevance of serum albumin in a cirrhotic patient. So I just had these comments.
Ma'am, we had seen earlier that midodrine does improve the complication, mainly the renal complications. So we just wanted to see that those which the midodrine is not being able to bring up, like survival or ascites control, are they being better controlled with an addition of albumin? That in our study in the RCT we could not find out, ma'am.
Yeah, we are saying that same thing, ma'am. The conclusions are same. The conclusions are saying that there is no difference. Adding albumin to midodrine makes no difference compared to midodrine alone. Yeah. So hence in our
Patients
setting,
also got albumin.
so
So actually both are needed.
so that is what we are saying. I mean, real life scenario, we would give midodrine and when required, we would give albumin for standard indication. That would what would happen in real life
I
scenario.
may have a very different opinion. Hypoalbuminemia does not need to be corrected all the time.
Yeah.
The patient has ascites, 2.5 albumin, and if you are tapping, it's all right. But that doesn't mean that if you are not tapping, just has ascites, every patient needs to be corrected. It is beneficial, but what you have shown is quite useful for general people. And I see in conclusion, there is no mention of the benefit of midodrine. Everywhere it looks like albumin debate.
Yeah.
So the whole idea is between the two, you should have said RCT. The summary slide should say the results are like this. You are only giving conclusion is probably different than what your data is. The study is very well conducted, and I think it adds useful thing.
Sir, I have some fundamental problems here.
Yeah.
Go to the title. So the title is one arm is midodrine, one arm is midodrine plus albumin. But till date, midodrine is not approved to be used for the ascites per se as a single agent. So this is the first error because midodrine is not a drug for ascites control. That is number 1. 2, when you go for any RCT, so one arm is midodrine plus albumin, one is midodrine alone. That means you are considering midodrine as the baseline standard drug. Albumin is the investigational agency. So that is not the fact because if albumin is the therapy, it should be on the both side. So that is not there. Hence, so this trial, I don't think it is a study has been conducted on the basis of rational scientific evidence. You tell me how a person having cirrhosis, there is multiple effects required by albumin, maybe osmotic, non-osmotic properties. Midodrine can address. Midodrine only can address the mechanism related to vasoconstriction or the hemodynamic hits. So hence you cannot compare that way. So it is should be the study should be albumin plus midodrine versus albumin only. Then you could have justified the midodrine has advantages or no. But midodrine giving both sides as a standard therapy, albumin as intervention is against the any standard recommendation for a study.
Sir, initially we had planned to do a study on midodrine plus
No,
albumin in one.
No, he's asking something. He's asking albumin plus midodrine versus albumin alone. So that was never our intention to check.
No, not your intention.
I'll
Study
show you
should be-
the data that was shown in the first few slides. So it was clearly shown that in the previous pediatric study, midodrine was showing benefit. It was improving the MAP, decreasing PRA, and
No,
decreasing
I'm
the
not stating-
AKI and better control of
understand.
ascites did not
No,
come, which
no.
has come in in the meta-analysis in adults, it has been clearly shown that it has better control of ascites. Two meta-analysis, big meta-analysis have shown that midodrine has better control of ascites in adults.
No.
So in pediatrics, we have got benefit. Now we want
The
to see whether
study is
adding
over, Ashok, the study is over.
नहीं study में वो नहीं पता
And,
sir I just want to suggest कि
I
sir
think
कोई
they
भी
should-
guideline no guideline recommended that metronidazole is a standard drug for ascites. Albumin is a standard
It's
drug.
not for ascites, it is preventing complications of.
No, but he is using for what? Indication for inclusion is what? Inclusion criteria for your studies.
Inclusion.
refractory ascites.
The last comments, now we're running
So
out of
inclusion
time.
is refractory ascites. It is not for ascites control.
Where is your inclusion criteria?
So having ascites only, this is a treatment is for ascites.
Decompensated cirrhosis awaiting LT, we want to prevent complications, sir. That's why we are using midodrine and albumin, and we have shown how midodrine and albumin will prevent
No,
complications
Then
mechanistically.
standard treatment
I
should be
don't
there.
find any issue with this.
Standard treatment should be there. Metodrine is not a standard
Standard
treatment for
treatment
ascites.
is in both arms, sir. SMT beyond that.
What is
Neither midodrine nor albumin is a standard therapy. Standard therapy is whatever is
No, the
approved.
diuretic dose and all, did they
No.
change as both Rakhi and Ashok
Those
said?
we have to show, sir. 100%.
The use of diuretics, the ease of giving diuretics, the intolerance to diuretics, did it decrease by adding midodrine?
Those I
That-
had discussed with him, sir, that we have to show 100% of our patients were
For
on
a-
diuretic because everyone was refractory ascites. But those we have to add on before submitting anyway.
Vikrant Vermity, I will ask to sir, when you go for any RCT, one drug which is in both the arms should be standard recommended. The second should be the investigational. Is it the justified treatment for RCT any? Is it a yes or no, sir?
That point is very valid. I think, but now since the student has
Because all
completed,
study has, no guideline has suggested that metodrine is a management for ascites. I am not telling about the study. I am talking about the study design. Any RCT, the recommended or the standard treatment should be in both the arms. Investigational should be in one arm. But you have done the reverse way. You have done the metodrine in both the arms, albumin in one arm. That means you are want to establish the benefit of albumin. That is a fundamental mistake of designing the study. That I want to say. I am not talking about that.
Okay.
Anyway, sir, the study was
Okay.
planned as midodrine plus albumin versus nothing versus SMT. And then it was advised from the board of studies to change it to the one which has been shown here.
right, thank you. It's
Sir,
a good
one more suggestion.
presentation.
One more suggestion from my side, go back, go to your limitation slide. Under the limitation, you have mentioned that this is a single center study. So this cannot be a limitation of the study because theses are mostly single centered. So you can remove this.
Yeah.
Okay, sir.
Okay. Thank you.
That is fine, I think, but we have to say that in when you send it for
Okay.
publication or send it somewhere, we have to write that as a limitation.
This is the
Do we have
Okay,
a
thesis,
second
but-
presentation? Any student, a second presentation? I don't.
Yes.
Okay, please go ahead. While you are waiting, Dr. Pamecha has got an award. Am I right? ISOT. So big round of applause for a individual award for Professor Pamecha, just conferred on him 3 days ago. It brings honor to ILBS. Thank you, Vinay. Go ahead. Who is the, oh, Dr. Pamecha is the guide. You need to sit there, Vinay. You have to be there on the DS with the student.
Morning, everybody.
And Naren, start.
Good morning, everybody. I'll be presenting my thesis titled Influence of Donor and Recipient PNPLA3 and MBOT7 gene polymorphisms on graft liver steatosis after living donor liver transplant for metabolic dysfunction associated steatohepatitis related chronic liver disease. My supervisor is Dr. Neendra Pamecha. Co-supervisors are Dr. Nilesh, Dr. Nihar, Dr. Gayatri, Dr. Shalini, and Dr. Archana. Coming to the background, MASLD is among the most common indications of liver transplantation in the recent times. This is due to the global rates of obesity and type 2 diabetes. And data shows metabolic syndrome persists after liver transplant, leading to the recurrence of MASLD in the allograft. Despite graft steatosis, risk of progression to advanced fibrosis and cirrhosis was low in the published data. And graft loss due to the post-transplant steatosis or MASLD was also uncommon. MASLD was shown to be a complex phenotype with both genetic and environmental factors influencing its incidence. And genetic and epidemiological studies conducted in various ethnicities worldwide indicate a strong heritability of hepatic fat content resulting in hepatic steatosis. Also, family studies demonstrate that first-degree relatives of patients with MASLD are at a much higher risk of the disease, a study which was conducted at our institute as well. Recent data shows increased susceptibility to MASLD in ethnicities from South America and Asia. And part of this interethnic variability is accounted in some of the studies by known genetic risk factors, in particular genes like PNPLA3, MBOT7, and TM6SF2. And these are the established risk factors in literature regarding the graft liver steatosis. Most established factors were obesity, type 2 diabetes, hyperlipidemia. PNPLA3 is the most established genetic polymorphism of all. Long-term corticosteroid therapy, and certain etiologies have high risk for recurrence of NASH. Recurrence or de novo NASH in post-transplant. And possible risk factors were sarcopenia and calcineurin inhibitors as immunosuppressant, and donor graft steatosis pre-transplant. And everolimus was shown to have some sort of possible protective effect in a few studies. The literature prior to this study, there were many studies in some studies in the Western population, but all the studies were done in deceased donor liver transplant setting. And major studies, one done in 2018 and in 2020 from Czech Republic. They were done in recipients with including all the etiologies for transplant, and all the recipients were from the DDLT cohort. No LDLT recipients were included, where they have done genotyping for PNPLA3 and TM6SF2 genes in both the recipients and donors as well. And they have studied graft steatosis with on the protocol graft liver biopsies, which they routinely do in their post-transplant population. In their studies, they have shown that PNPLA3 confers a genetic predisposition to liver fat steatosis, and they have shown that recipient PNPLA3 does not have a significant effect, but it is donor PNPLA3 showing the transcription on the liver as a central mechanism rather than a peripheral mechanism in the recipient's body. And the other study followed up by them included both the genotypes, where they showed donor TM6SF2 allele also as an independent risk factor, which has an additive effect to the already established role of PNPLA3. There are other studies done, even these in the DDLT setting, which have also shown the role of PNPLA3 in the de novo NAFLD incidence in post-transplant setting. And there is one study which has shown MBOT7 genotype also having an effect on de novo and recurrence of NAFLD and post-transplant graft. And this study is exclusively done on NAFLD patients, but done in a non-transplant setting, where the patients who already had NAFLD on their OPD follow-up, they underwent liver biopsy, and these are patients who are awaiting transplant. So the lacunae is till now there was no study done in exclusive NASH or MASH recipients, and there is no study done exclusively in living donor liver transplant setting. So all the existing studies are from DDLT cohorts, and LDLT data is very limited. And most of these studies have contradictory conclusions, with some of the studies showing effect of recipient genotype having more influence on the post transplant steatosis, and some showing donor genotype having more influence. And this proposing this study in the setting of LDLT gives us a chance to assess both genetic and environmental factors, as most of the donors in Indian LDLT setting are from the family of the recipient itself, thereby sharing the same environment. Our primary objective for this study was to evaluate the determinants of post-transplant graft liver steatosis in patients who underwent living donor liver transplant for metabolic dysfunction associated steatohepatitis related CLD. And secondary objective was to assess the impact of both the donor and recipient PNPLA3 and MBOT7 gene polymorphisms on the development and severity of graft steatosis following living donor liver transplant. It was an ambidextrous analytical study. All the adult LDLT recipients whose etiology was MASH, and their donors who underwent their transplant at least 3 years prior to the onset of this study, who came for a follow-up visit during the study period, were included, and pediatric transplants and ALF, ACLF etiology were excluded from the study. So methodology was genetic genotypes were done using PCR restriction fragmental and polymorphisms, and hepatic steatosis was measured in the recipients using FibroScan, control attenuation parameter, and CT liver attenuation index on a non-contrast CT scan performed during their follow-up. And the grading of steatosis was taken as S0 with a CAP score of less than 248, mild with a CAP score between 248 to 268, and moderate to high as more than 268. And the corresponding LAIs were also mentioned, with no steatosis as more than +5, and the mild steatosis +5 to -10 Hounsfield units on non-contrast CT scan, and moderate to high-grade steatosis as less than -10 Hounsfield units. So our cohort contained 48 recipients and their donors. Medium time since transplantation was 5.5 years, and the range was between 3 and 10 years. So we had a minimum follow-up time of 3 years post-transplant. And 34 donors were genetically related relatives, mostly sons, daughters, or siblings, and that is 76% of the study population. And 11 donors were genetically unrelated, predominantly spouses, and in 9, and in 2 other relation. All the recipients were initially managed with triple drug immunosuppressive regimen consisting of tacrolimus, MMF, and prednisolone during the early postoperative period. But at the time of follow-up during this study, most of the patients were on tacrolimus monotherapy, while a smaller proportion continued to receive dual with tacrolimus and MMF. None of the patients included in this study were on corticosteroids during the follow-up. So this is the baseline characteristics of the 45 recipients included in the study. With a mean age of around 52 at the time of transplant, and at follow-up it is around 57 to 58 years, and 84% of the patients were male, and their donor variables at the time of transplant, a mean age of the donor was around 30, just about 33 to 34 years, and the mean BMI of the donor was just about 24. And in 84% of the cases, right lobe graft was taken, and mean BMI at transplant was 26.1, and at follow-up it is 28.2. And the triglycerides, AST/ALT at baseline were not included, because those at the time before transplant usually indicate the severity of the disease and a lot of influence of the pre-existing liver disease. So at follow-up, Mean triglyceride levels were around 170. AST, ALT were 34 and 42. And incidence of diabetes in these patients at transplant was around 53% and at follow-up 62%, with glycemia HbA1c level of 6.2 at the time of follow-up. And 26% were hypertensive at baseline and 40% at the time of follow-up. So these are the characteristics in according to the grade of graft steatosis. So the first column with no graft steatosis, the second is S1 mild, and moderate to high grade steatosis is in the third column. With BMI not statistically significant, but it is having a higher trend towards high grade steatosis, with 25.7 in the no steatosis group and around 28.4 in the moderate to high grade steatosis group. And triglycerides were significantly higher in the higher grades of steatosis, with reaching more than 200, 250, mean being 192. AST, ALT were not significant, and they did not show any trend towards steatosis. And incidence of diabetes has a higher incidence towards higher grades of graft steatosis, with around 85% in the higher grades being diabetic, and hypertension did not show any trend according to the steatosis. So this is the genotype data. Bar chart showing recipient and donor PNPLA3 genotypes. The one on the left hand side shows the recipient PNPLA3 genotype according to the steatosis grade. So in the no steatosis group, the 0 denotes wild, and 1 denotes heterogeneous and heterozygotes, and 2 denotes homozygotes for PNPLA3. As the steatosis grades go towards a higher grade, so we have observed a tendency towards homozygous PNPLA genotype. And in the donors as well, this was observed with the grafts from the PNPLA3 homozygous donors tend to have high grade steatosis at the time of follow-up. And this is the genotype data showing MBOT7 genotypes. Left the chart denoting the recipient genotype, and the right chart denoting the donor genotype. Coded similarly, 0 is wild, 1 is heterozygotes, and 2 is homogeneous. And even this showed a trend towards homozygous recipients having high grade steatosis, but this was not seen in the donor genotyping data. So we have also included the total number of risk alleles, where we have added the number of alleles irrespective of the recipient donor in both the genes studied. That is, we have added the total number of risk alleles from PNPLA3 in both recipient and donor, and MBOT7 in both recipient and donor. So this gives us a score between 0 and 8. When both the recipient and donor are wild type for both the genes, the number of risk alleles being 0. And if both of them are homozygous, for both the genes, it would be a higher risk with the risk alleles of number 8. So the range would be between 0 to 8, total number of risk alleles of both the genes. And this has shown a statistically significant trend towards high grade steatosis. This graph shows a correlation between on the y-axis it is liver attenuation index seen from the non-contrast CT at the time of follow-up, and on the x-axis it is a total number of risk alleles. So this is the negative correlation, as lower LAIs, that is negative LAIs, suggest or denote high grade steatosis. So there is a very clear negative correlation between both the factors. And this scatter plot shows incident, the occurrence of between the triglyceride levels of the recipient at the time of follow-up and their BMI, and the the steatosis grades are plotted on the graph, representing their dispersity between triglycerides and BMI. And overall, there is a trend where the recipient has dyslipidemia along with a high BMI tend towards having high grade steatosis, as denoted by the blue plot. And we have also seen the longitudinal changes in steatosis grade after transplantation, that is time after transplant. So the first bar denotes all the patients or recipients who are between 3 to 5 years post transplant, and the second one between 5 to 7 years post transplant, and the final one is more than 7 years. That is, in our study, it is between 7 to 10 years post transplant. So we have seen a trend towards increase in the grade of steatosis as the time progresses after transplant. And we have also compared the results with the donor relation to the recipient, where we have seen 34 pairs were genetically related and 11 were genetically unrelated. Where in genetically unrelated, most predominantly the spouse who has donated, and in 2 cases it was other relative. So there was no significant difference in recipient or donor genotype frequencies between the both the groups, whether genetically related or unrelated. And a distribution of total risk alleles was also similar. No major inheritance bias observed in this transplant cohort. And we have also generated genetic and metabolic models based on pseudo R square scores, where we have included all the 4 genotypes, whether MBOT7 and PNPLA in both the recipient and donors, and the total number of risk alleles. So 5 parameters we have included in the genetic model, and we have included all the metabolic parameters in the metabolic model, and then we have seen that the metabolic model has more effect denoted by its high pseudo R square value over the genetic model, but combined model, where we included both the genetic parameters as well as metabolic, showed the highest effect. So combined model provided the best overall fit. This highlights the synergistic effects of both metabolic and genetic traits on the graft liver steatosis. So, summarizing our results, the recipient PNPLA3 genotype was found to be strongly associated and statistically significant, even in the multivariate analysis we have conducted, with moderate to severe graft steatosis in the post-transplant setting. And this variant impairs triglyceride breakdown, promoting the lipid droplet accumulation, as was shown in many in vitro and in vivo studies as well. And recipient genotype exerts greater influence than the donor genotype, as we have shown, as our data suggested. So the donor PNPLA3 variant showed statistically non-significant, but definite trends towards severe steatosis, but which was not statistically significant. And this suggests a possible additive or synergistic effects when both the donor and recipient risk alleles may have synergistic action. And the clinical implication being donor genotyping may assist in the selection of borderline steatosis cases, where currently we go for liver biopsy in borderline cases in the selection criteria. And coming to the role of MBOT7 variants, these genotypes were not significantly associated with graft steatosis in our cohort. But the homozygous genotype mildly more frequent in severe steatosis grade patients, suggesting modifying role for this genotype. Metabolic factors likely might have overshadowed the genotypic influence of this gene in our context. And coming to the aggregate risk allele burden, which we have included in the study, where we have taken the cumulative risk alleles of both the genes. This has correlated with CAP and CAP score as well as the LAI, and more than or equal to 5 alleles, risk alleles in the total risk allele score is seen to be associated with higher grades of graft steatosis or fat content. The steatosis severity tends towards higher risk allele burden. This also supports the polygenic contribution to NAFLD or graft liver steatosis, which was shown in the literature as well. So the metabolic drivers mainly being diabetes and hypertriglyceridemia. In our study, in the multivariate analysis, diabetes and hypertriglyceridemia were the strongest predictors of steatosis. And interestingly, the glycemic level was not found to be significant, even if the sugars were under control. But the patient having diabetes itself was an independent risk factor in this study, even with very good glycemic control. And BMI also correlated positively, but it was not significant in the multivariate analysis. And the longitudinal time, that is steatosis progression, was more evident and towards high grades beyond 5 to 7 years post-transplant. On comparison with the early literature, our findings also reaffirm that PNPLA3 as a dominant genetic determinant, as shown previously in many of the studies in the Western populations. And effect of the other genotypes, donor PNPLA3 and both recipient and donor MBOT7, diverges from the literature or the data shown from the Western cohorts. This might suggest a potential ethnic, environmental, or sample size difference as well. And overall, this supports the polygenic metabolic interaction model, which was proposed in many studies. The recipient genotype significantly predicts post-transplant steatosis severity, and the cumulative risk allele burden also correlates with severity. And the metabolic factors, diabetes, BMI, and triglycerides remain the dominant contributors for post-transplant graft steatosis. So, genetic predisposition acts synergistically with the metabolic factors, influencing long-term graft outcomes. And clinically, this can pave a path for integrating genetic screening and metabolic optimization to enhance the surveillance in the post-transplant setting to improve the overall graft outcomes and patient survival. So the strength of our study was this was the first study evaluating two genotypes of PNPLA3 and MBOT7 in an LDLT cohort with an exclusive etiology of MASH-related CLD. Limitation was a single center study with a relatively small cohort size of 45 pairs, limiting the power for subgroup analysis. And MBOT7 association may be underpowered due to low variant prevalence in the studied population.
For a surgeon, this is a great feat. I think you did a good job by understanding and presenting well. First, I'll ask comments from the guide, Dr. Pamecha.
So thank you very much. So first of all, I would like to thank Gayatri. Obviously, Naren has done the collection data and Gayatri has done all the genetic work and all the other co-authors in the thesis. This was actually when we started, the thought process, how it came to us is basically what we're seeing is a lot of patients with NASH are coming for transplant. And then you have first degree relatives, either son or daughter, donating for them. And then you start thinking most of those donors actually require lifestyle optimization before they can become fit to donor. And then you keep thinking that, what will happen to this guy who's going to donate 65% of their liver to their father or mother. And then in the long term, that's one issue. And then what will happen to this liver, which at this stage may had an optimization done, but longer term, both the factors will keep playing, the genetic and the kitchen. So how they are going to influence the graft in the longer term as well. So that was the whole thought process of doing this work. I think we've done reasonably well in terms of from where we started. So one thing which comes out here is still lifestyle optimization needs to be done more important than the genetic one. And then if we are assessing and we have a borderline donor whom we think that maybe is not a good pair, then we should think of doing a genetic analysis. And if they have a homogeneous component, then maybe we should try and find if there is another donor in the family, or they can wait for DDLT, because this at that moment the transplant may happen, but in near future or long term, the both of them may run in problems as well. So that's what I get from this. And obviously it's open and sir can comment as well.
It's very nice, and it opens a new chapter, entirely new chapter of looking at transplant and the post-transplant outcomes. A few comments just to improve. Can you go to your allele slide? I'll try and help you improve. Yeah, this one.
Yes.
So you have to give weighted allele. One is allele. The frequency of allele has to be weighted as per the importance of that allele. And there are methods and softwares where you can give weighted allele score, like polygenic risk score. You mentioned polygenic. It's not the number of alleles. Point 1. Point 2, you go to your PNPLA. PNPLA, no, the initial, which mutant are you taking? The common mutant, the one which is isoleucine to methionine, IL148M.
Yes, sir.
So you have, but that is not so common in India. We have about 2700 database. So that is not the commonest allele. The second common allele is the glucine, GLU to M. So look into both variants, and Gayatri can certainly help you.
Yes, sir.
Third, MBOT is related to phospholipid. You know, it is the PNPLA is a hydrolase of the, triglyceride hydrolase. It's a main breakdown. So if it breaks, then VLDL will come out. But the MBOT is a phospholipase, phospholipid. So that is not so important. What is important in India maybe is GCK, maybe PCSK, maybe SOD. So look into other genes, and I will definitely discuss with Gayatri to look into it. Number 4, go to your conclusions. Yeah, so now you have to see the frequency, the homozygosity or heterozygosity in the donor and in the recipient. Make a pair. They are in the same family. Then if the father, let's say, had homozygous PNPLA, the homozygosity of PNPL in India is about 4 to 6%. In US, China, it may be 30%. So PNPLA3 recipient and donor are both having homozygous. If not, homo and hetero or both hetero, what is the rate of progression of your steatosis? Suppose both had it, maybe your steatosis. So you can open up what is called as a walking gene theory. Both are homo, the steatosis became faster. So this opens a whole new chapter of metabolic transplant. You're transplanting genes and metabolites and metabolism from one. So I would put it genetic and metabolic transplant, and it opens a new chapter. Of course, many more things can be done. Any other comments, Dr.?
We have tried doing that analysis as well, sir, comparing both the donor and recipient, but due to the limited sample size, it was not significant, so we have not included it.
You can go back and continue anyway.
Yes.
Dr.
Naren, how many of them did you look into when you're reviewing had nodded, diabetes after the transplant?
So
Or all of them were pre that? I think you did show in the beginning. I just missed.
diabetes after
Achha.
yes, sir. After transplant was overall
You
it
said-
was four patients are more in the
So
follow-up group.
baseline 24,
Baseline
53%.
But in these 4 patients, diabetes got reversed. It was
Okay.
resolved. So
Okay.
eight patients developed NODAT.
Not that, yeah, that's what, yeah.
Gayatri, are you around? Any comments from you, please?
Gayatri, please.
Don't have much of a comment. He's already explained it out, except we agree with what you said to give weightage to each of those risk alleles and then redo the calculation.
Thank you. Very good. I hope it publishes well, but continue.
Thank you, sir.